Welcome back, everyone. For those of you who don't know me already, my name's Andrew. I'm a registered polysomnographic technologist. I studied chemistry for the medical sciences in my undergrad, and I'm now a master's student in sleep medicine at the University of Oxford. And I also work at the Sleep and Brain Clinic in the Bay Area with Dr. Anil Rama. Did you know that 30 to 50% of patients with obstructive sleep apnea also have insomnia? In this discussion, Dr. Barry Krakow and I are going to discuss the principles of insomnia so that if this is a difficulty that you're facing, you can start to know what you can do about it. I'm going to pin all of Dr. Barry Krakow's information below, so if you'd like to work with him one-on-one for sleep disorder breathing or insomnia, or explore his other services or some of his books, which I've mentioned in past videos, then you can do so. The reason I wanted to include a video on insomnia is because there's a lot of overlap between insomnia and sleep disorder breathing. In fact, there's an entire category called COMISA. Don't worry, I'm not going to turn this into an insomnia channel. If you would like one-on-one help with your PAP therapy, to have a sleep study rescored, or have a sleep study sent to your house, you can explore my services below as well. For those who haven't been exposed to you yet, and just as a reminder for those who've seen the other videos that you and I did together, what is your background?
So let's see. My background is that I got accepted to medical school in 1971, and for a lot of reasons didn't go. So I spent 8 years being an accountant, running a natural food grocery store, and opening up a natural food restaurant. And that lasted for 8 years. And then finally, when I was 30 years old, I went to medical school, then did a residency in internal medicine. And in Albuquerque, New Mexico, spent another decade doing emergency medicine. And finally, through divine providence, I got involved in this nightmare treatment research program in the Department of Psychiatry at the University of New Mexico. And from that point forward, which was 1988, to the present, I've been very much involved, if not full-time involved, in sleep medicine clinically or research or both.
And are you practicing now?
I have a coaching practice. When we sold the sleep center in Albuquerque and moved to Savannah, we decided it was time to get rid of or just break away from the difficulties that we're seeing in healthcare now with the insurance companies, with the types of managed care where so many doctors are practicing cookie cutter medicine. I wanted to fill the void of what I believe is the biggest gap in sleep medicine, and that is the education that's given to the patients is horrendous. The individuals are walking away from their DME, from their sleep tech, from their sleep doctors, and they just don't know anything. They don't know anything about their choices. They don't know anything about the fine tuning. There are so many people unhappy with sleep centers all around the world, and they don't know what to do. Most of them quit. Most of them just say, well, it didn't work, so that's it. I'm not doing anything. Or they go someplace and say, well, at least give me a pill. Maybe this pill will solve my problem.
Have you seen that change a lot over the years, or do you kind of see it as similarly bad to what it was 20 years ago? Have things improved from your vantage point or
I
not?
think I think it's clearly gotten worse.
Really?
Clearly. Oh yeah. Oh yeah. Because what's happening is there's no clear freedom of thought that goes into asking the question about, well, if this doesn't work, what do we do? Best example would, of course, be CPAP. If it doesn't work, you have literally millions of individuals who have been told, well, CPAP is your only option. If you can't get it to work, I don't know how to help you. Maybe you can get a dental device. Maybe you can get Inspire a nerve stimulator. But if you can't use CPAP, I'm sorry, I don't know how to help you. And so you've got doctors literally not reading the scientific literature on bilevel, on ASV, on why CPAP is actually a horrendous device for 2 out of every 3 patients that attempt it. And instead of the doctors being, oh gosh, I'm seeing this pattern, I wonder what we can do about it, they're saying, I have nothing else to give to you. And of course, they're nervous because insurance companies say, oh, well, why are you prescribing bilevel? You're an outlier. We're going to have to keep a watch on you. You want more studies in the sleep lab. That's another reason why it's got worse, has gotten worse, because they're trying to get the sleep doctors to no longer bring people into a sleep lab. And so there's all kinds of information being missed.
That it resonates very deeply with me. I'm not going to hijack the interview with my own personal story, but just to jam it in there, I grew up in Canada. I studied biochemistry, so a little bit of context. And that's exactly what happened. I went to see the ENTs, the OMFSs, the sleep docs, pulmonologists, and they literally said, you have mild apnea. There's nothing we can do. All of them. And none of them offered another solution. One of them was pretty open-minded and kind of wanted to stick with me and not just get rid of me. But
Mm-hmm.
and I was thinking like because I started to read the literature because I was trained to read literature through my schooling, right? And I was going, well, that's not true. Like there's all this literature that says that there are other things and that actually I do have a problem. AHI doesn't tell the whole story. And it was just a dark place to be in. That was like 8, 9 years ago now. I ended up going to the States. I saw Casey Lee, Breathe Institute, LA Comms, etc., Dr. Neil Rama, and
Mm-hmm.
reading this stuff myself. And now, as I told you, I study it. So I get it now, but back then I could have easily sort of, which I think a lot of patients do, go, oh, I guess there's nothing that can be done. The doctor said, and they know, right? The doctors know. I guess there's nothing that can be done.
Yeah. And here's the epitome of this in terms of the modern world. Like when you think of innovation, or you think of like, um, where might there be some really new things that I can think and talk about? You've got a guy like Joe Rogan, who has on his show Matt Walker. And nothing against Matt Walker. He's a great researcher, a brilliant mind, but he's not talking about clinical sleep medicine the way I will talk about it today. He's talking about the big umbrella problem of, well, people aren't getting enough sleep. And fair enough, that's a very important point. And again, I would told nothing against Dr. Walker. I very much uh, appreciate all the work that he's done. But you would think that somebody like Joe Rogan would have picked up on the fact of, wait, why are there so many people failing CPAP? Joe Rogan, by the way, failed CPAP. And I think he ended up on a dental device. I doubt seriously he's getting a great treatment, but he might think he's getting a great treatment because that's how everybody tends to normalize this. So that's the epitome, I think, of what's going on, where this information is just not getting out there, that there's so much more to do. And one day it'll break through. You never know how long it takes, but eventually it gets into the mainstream, and we hope to see it one day.
Yeah, I want to lay something on top of that. I completely agree. You know, if Joe Rogan, if you ever listen to this, I think there's a very, very vanishingly small probability that you do. But he could completely shift the landscape of sleep medicine in one sentence. In 2016 or 17, I was listening to a podcast when I was working at a construction site, and it was Joe Rogan, and he was talking about sleep apnea, and he very like briefly mentions this mouthpiece. It's called the full breath solution. I'm not sure if you ever heard of that one, but I of course go home and start researching, and I find some really old Twitter post that had an address attached to this name, a full breath solution that Joe Rogan name dropped. So I call it and I call it and I call it. Eventually, this lady calls me back. I don't know if I should name drop her here. I'm gonna name drop her. I might edit it out though. Her name was Beth Settle, and she worked with this doctor in Beverly Hills named Dr. Eric Karopian, who passed away a few years ago, who was the inventor of this mouthpiece that Joe Rogan ended up using. She calls me back. This lady, I would argue, saved my life. She was the first, she spent 2 hours on the phone with me. I'd
Mm,
never met her
mm,
in my entire life, but she
mm,
was in the space. You know, she was very well aware of the fact that AHI is not
mhm.
everything, upper
Right.
airway resistance syndrome was swirling around, right? And
Mhm.
she was very aware of patients who fail CPAP. Anyway, I get like end up getting 7 different designs of this device. It was an
Uh-huh.
improvement, but it wasn't
Hmm.
long-term solution. But I just wanted to add that because I think that listeners will appreciate that little anecdotal story. And it ties
Yes.
into the fact that, yeah, I really do think, these people with massive platforms, if they said one little thing, it could make more progress than, we've seen in the last 5 years. Anyways, so today
Ah,
was
on to insomnia.
exactly onto
Uh-huh.
insomnia. So just to set the table, can you just some people might not have any idea what insomnia is. So how would you describe it? What's the elevator pitch of what insomnia is?
Well, it's great the way you asked the question because the truth of the matter is that a lot of people don't like the word. And so it's so stigmatizing in some circles that if you describe this exact thing and you said that's insomnia, you've got tons of people who go, oh, but I don't have that. I don't have insomnia because insomnia means there's got to be something wrong with me. It's a performance. I can't sleep, so there's something wrong with me. Insomnia literally means, you have trouble falling asleep at night. You have trouble with too much awakening at night and often can't get back to sleep at night. And it almost always includes something about the quality of your sleep not being, where it should be. So it's any of those things, or it can be all three. However, um, as I said at the outset, you can hear that and you can go, well, yeah, I have that sometimes, but I don't call that insomnia. So I'm just putting it out there that there are literally millions and tens of millions of people who don't like to hear that word, which is its own stigma, just like in the whole field of mental health. Who wants to be diagnosed with depression? Who wants to be diagnosed with anxiety or PTSD? So it's a very common in that regard. And it's so interesting because if you do have insomnia, the chances that you have a mental health symptom along with that are greater than 95%. It's extremely rare to have insomnia and not have something else going on.
How does a doctor figure out if you have insomnia? If it is this thing in the head, is there a test? Do you have to do a sleep study? Like, how do you figure it out? And how good are we at
It,
figuring that out? Is there a lot of wrong diagnoses and missing diagnoses?
no, it's just missed. It's just completely missed and overlooked. In other words, ask the question of how many doctors ask a question in their little screening surveys now of how are you sleeping or how good is your sleep or something like that. Nowadays, in primary care, you can actually see a few more doctors asking those questions. But insomnia is simple. You just say, you have trouble falling asleep. Okay. Does this occur like once a week or more than once a week? Oh, really? Okay. You got insomnia. Um, do you wake up a lot at night? By the way, waking up a lot at night is much more common than difficulty falling asleep. Difficulty falling asleep is common in a sense in younger people, and it can be very severe, very problematic. But as we age, the sleep deprivation that eventually hits every insomniac makes it so that now they get into bed and they pass out, and then they start waking up like crazy and they can't get back to sleep. In a doctor's office, you could say, do you have trouble falling asleep? Do you wake up a lot? You have trouble going back to sleep? Oh, and by the way, how do you feel after you wake up? Any of those questions. It's like, oh, well, then there's something wrong with your sleep. And you can just stop right there. You could say, well, do I want to send them for a sleep test? Well, really, you would do that if you're thinking sleep apnea. And largely, when you deal with insomnia, because there's a psychological component to it and a psychological reputation to it, most people who have insomnia won't go for a sleep study. And if you told them to get a sleep study, they go, why are you telling me to get a sleep study? I just told you what my problem is. So most primary care doctors know enough about this little bit we've talked about, and they might say something like, well, have you tried sleep hygiene? Or they might pull out the prescription pad and say, would you like a sleeping pill?
And that's, would you say, the vast majority of the responses? And what is the correct response? Let me start here, actually. Let's step back one sec. How many, are there different types of insomnia? You know how in sleep disordered breathing, there's the upper airway resistance syndrome or the low threshold of arousal type
Mhm.
phenotypes. And then there's other people who violently snore and desat all night and have
Right.
AHIs of 50. Is there something similar in insomnia, or is everyone kind
Yeah,
of in the same box?
no, there's always variations of insomnia, but often they have similar roots. It's just that as as professionals get more involved in their own work, they try to dice and splice things in a way to say, oh, well, this is this niche over here, the people with sleep state misperception insomnia. And these are the people with sleep maintenance insomnia. And these are the people with sleep onset insomnia. And sometimes those tags can be useful. However, it is often very similar. In other words, it's often very similar that there's a reason people don't sleep. In other words, you have what's called unwanted sleeplessness. And so it is a condition of sleeplessness that is unwanted that you are suffering from once a week, 5 nights a week, every other month, whatever the pattern happens to be. Most people with chronic insomnia who maybe get diagnosed eventually could have had the problem for 5 to 10 years before anybody meaningfully interacted with them to say, well, wait, have you thought about getting help for that? And the person would say, what help is there? I don't want any pills. The largest majority of people don't want pills unless they go to the drugstore and they get their, over the counter sleep aids. And that's what a lot of people do and when it gets desperate.
How do we fix insomnia? And why are all these patients being left for 5 to 10 years? It seems like a pretty obvious thing to ask, no? Like if you're not sleeping well?
Well, first of all, you have to take sleep seriously. And as we've described along many over the years, and many people, I just read another article somewhere describing the same thing, that doctors didn't respect sleep when they were going through medical school and residency. And that sets them up to not respect the sleep of their patients because they go, well, I toughed it out. What's the big deal here? So that happens a lot. So there's no respect for sleep in general. But there's also a sort of history that most of us are forgetting. Excuse me. There's a history that we're forgetting in terms of how does insomnia play into culture. So this is what I try to say to people. Pretend it's 100 years ago, or 200 years ago, 500 years ago. Go back as far as you want. And some week occurs to you, and during this week, you have trouble falling asleep. What are you going to do? And the person looks at you, go, well, I guess there's no sleep doctors back then, right? Maybe drink alcohol. I said, right. That was be the number one treatment. In fact, it still is the number one treatment for insomnia. I'll just drink. But this is much more important than the drinking alcohol, although the drinking alcohol is highly relevant to what really happens. Amongst the persons, the individuals who have a little bit more self-awareness, they're going to go and talk to somebody. And who are they going to talk to? They're going to talk to somebody they're close with. It could be a spouse. It could be a cousin. It could be an uncle. It could be a grandfather. It could be a minister. It could be a rabbi. It could be somebody that they have a close relationship with and they have genuine conversations with. Can you guess this special person they go talk to? Can you guess what that person's going to say when the person who's got the insomnia comes to them and says, hey, Joe, blah, 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 and you have trouble sleeping, blah, blah, blah. What is that person going to say to them? Got any ideas?
Mm, assuming they're a loving, caring friend, maybe they might ask, what's going on?
I love it. I love it. That's exactly what they're going to ask. It's that simple. And the person's going to go, what's going on? Oh, what's going on? Oh, what's going on? Oh, yeah, now that you mention it. And that's why they went to that person, whether it was consciously or unconsciously. What was going on is what's called unfinished business. And that unfinished business is either intellectual, it's emotional, it's practical. It is something going on in their life with relationships with other people that are conflicts, some conflict with work, some conflict about worries about money and food, self-esteem. Whatever it is, it's always unfinished business. There are rare exceptions in that there's people who deny that. Those people have even worse insomnia. And I want to make sure we come back to that at some point because that's a dead ringer for if you answer that question, nothing is going on, that insomnia may be almost impossible to treat without pills because it means the individual lacks self-awareness and does not really want to deal with what's going on. So if that is the root cause of most insomnia, and by the way, there are plenty of old school family doctors, internists, primary care doctors who will do what we just said. They are smart enough to say that. Nowadays, though, if they've got like, what is it, 5 minutes to have a conversation with the patient, they may not be able to get that question in, which is makes healthcare, even more deteriorated because of that. But that conversation will bring to bear this thing is happening in the life that is causing it. Now, where do you go with that? Well, for some people, it turns out that having a good conversation with a friend and venting on the one hand, but also saying, gosh, I didn't think of that. That's a good idea. Maybe I could try that. Next thing you know, the insomnia is gone. So that is the largest bulk of what's really going on with insomnia. However, because these people have had the condition for years, it develops into a chronic pattern. And that's where you have the ideas of behavioral sleep medicine coming forward saying, well, oh, even that could be true. That whole thing could be true. But really, we just need to do some cognitive behavioral changing about the way these people have learned to see their sleep so that we can get them out of their rut. And then that will, in fact, treat the insomnia. So that is a true statement because CBTI does work for a certain proportion of people if given properly by the right a professional who knows how to deliver it properly. However, in my clinical career and in my coaching services, I tend to work with people with very severe insomnia, and they've often failed CBTI. In fact, they've often failed CBTI twice or 3 times. And I'm going, can you tell me like what happened, like why it didn't work for you or what you think, And so at bottom, it was very clear that nobody went back to, well, what's going on in your life that actually could have interfered with all of that. And so then you say, well, does that mean these individuals need psychotherapy? That's a very good question. That's a very fair question. And while it may be true, it really needs a special kind of psychotherapist who's going to understand the nexus between sleep problems and therapy issues and do it in a way that doesn't say, yeah, we can fix your insomnia, but we're going to have to spend 2 years first on your trauma. And like when your trauma is better, maybe in 2 years your insomnia will be better. I'm not trying to say it that outlandishly, but I'm pointing out there are patients who've heard that kind of conversation and they think that's what the therapist is saying. They're saying, you mean just like stay on my sleeping pills until we do the PTSD treatment? And the therapist might say, well, if that's what your doctor or psychiatrist recommends, then by all means, just do that.
So, if I'm understanding correctly, one of the sort of first obvious things to try with someone who is having insomnia is just a conversation that digs into what's going on so that they can sort of cathartically express themselves. Is that fair to say?
Absolutely. Absolutely. And it's so essential because it makes the person feel heard. And it also makes the person go, oh, gosh, I didn't realize how much influence this was having on me, with one caveat. And that is if it's that chronic, the real value that comes up for this is to say, hey, do you remember when your insomnia started? And like 50 to 90% of people will go, well, I remember it was like a couple of months after the divorce. It was a couple of months after my mother passed. It was a couple of months after I moved. And so right there, you get to say, oh, well, did you see the connection then? I say, yeah, I did see the connection, but I didn't know how to get out of the loop. I just was really upset and things were weighing on me all the time. So now we get into a realm that I've written about in my books, which are some people with insomnia have to be given an opportunity to understand they do not have an emotional processing system in place that works well for them. So when you speak to the typical chronic insomniac and you ask them the question, do you suffer from anxiety? Most of them will say, yeah, I'm kind of a worrier. I think I have some anxiety. And so you go, it's a trick question, but it's very revealing. You go, I'd like you to tell me where you feel that anxiety. And the most common answer would be, I notice it sometimes at work. Uh, Sometimes I do notice it, when I'm, getting ready to go to bed. And I stop them. I say, we're miscommunicating. I'm sorry. I'm not exactly trying to trick you, but I'm asking you, where do you feel anxiety? And they go, oh, you mean like where do I feel it? Oh, well, you mean right here, right? Like I know I worry right here. I said, okay, well, you've just defined the problem then, because emotions, while you can register them intellectually with a name and a label in your brain, if you are not capable of feeling your emotions in your body, and in particular in the region that is closest, so to speak, to your heart, where you can, again, so to speak, listen to your heart, that means your type of emotional processing is about intellectual, rational ways of dealing with emotion. And sometimes those ways are perfectly valid and useful. But most chronic insomniacs do what I just said. They think the anxiety is up here. They don't know how to process feelings here. And I say to them, well, we can go down a couple of paths here. We can go down CBTI, but remember, you told me you tried CBTI and you said it didn't work. And you tried to explain why it didn't work. And I've been listening to you. But we've also discovered there's something very intense that you're experiencing at your work or in this relationship or something else going on in your life. So, should we do CBTI again? Or should we maybe talk about the way you have learned to cope with this difficult emotion? And the people who go through this don't have a ready answer until you explain one or two principles about insomnia that are so universal that once they hear them, it gives the individual an option to say, well, I could consider either one. So one principle is most insomniacs that are chronic do not understand the difference between being sleepy and being tired. The other one is most people with insomnia do not understand that racing thoughts in your mind is the cardinal symbol of unfinished business. Instead of dealing with your emotions, you've chosen, consciously or unconsciously, to let your brain ramp up to warp speed because you're under the delusion that that will solve the problem. That you're smart enough that you've figured out lots of problems in your life. So why can't you figure out this problem, whatever that problem happens to be? So when insomniacs start to hear these two principles, like, well, you have racing thoughts because there's something that's bugging you, they're not random. somewhere in those racing thoughts, you're going to find at least one that's very personal and very relevant to what's going on in your life. And we could work on that one and say, all right, what is that unfinished business? But the other thing is, if you want a quick solution, you've got to ask yourself the question, are you going to bed when you're tired? Or are you going to bed when you're sleepy? And again, with chronic insomnia, the more severe it gets, do you realize that they have blended tiredness and sleepiness? They have no clue what you're talking about. They go, what do you mean? I get into bed when I'm tired. Okay, well, what does that mean? Well, it's 11 o'clock. It's my bedtime. Okay, yeah, but how do you feel about, well, it's my bedtime. I'm supposed to go to bed then, so I get into bed then. But, but do you feel drowsy? Do you feel like you're going to fall asleep? No, I never feel that way. I go, okay, well, we got a problem here. You're telling me you never feel sleepy, but yeah, you keep getting into bed and giving yourself the message, hey, let's go into bed and spend a lot of time thinking and worrying and tossing and turning and being tired and demanding that I fall asleep because I have a right to fall asleep. And in fact, a person does have a right to fall asleep. It's biologically, what's the word? It's within your biology that you will fall asleep eventually. But if you do it in that particular way, trying to take control of your sleep, it's not going to work.
Okay,
Okay.
so tired versus sleepy. A lot of people say there's no difference. Is that true? Doesn't sound like it is. I'm kind of asking a rhetorical question. So how do you begin to tease these two concepts apart for an insomniac? And how and why is it important?
Right. Well, it's extremely important because if you have, and again, I mostly talk about chronic and severe insomnia because those are the people that are so desperate and so much in need and getting so little help from the mental health community in particular. Um, Tired and sleepy is very straightforward. As long as the person has an intact memory, they know they've fallen asleep in church, they've fallen asleep in a movie theater, they've fallen asleep in a lecture at some point in their life. And they go, yeah, well, what was going on then? Well, you were drowsy, you were sleepy, your eyes were heavy, and you went to sleep. And yes, they can say, well, I never have that now. I say, well, you're right. You're right. I'm not telling you, something you don't know. I'm saying you did have that and you can have that again. But if you make the mistake of using the word tired to describe things as if that's the be all end all, then you're going to lose out. Because if you go to bed when you're tired, that means you're basically wired, which is the opposite of being sleepy. And you are exhausted, you're frustrated, you're angry, you're demanding your sleep, you want to take control of your sleep, and you go, well, I'm just going to get into bed and make it happen. I'm going to make myself fall asleep, which of course never works. So I hear your frustration. I hear that you want this to happen. I'm simply explaining that if sleepiness is something so removed from where you are and you think there's no hope for you and you feel you must take sleeping pills, then that's the decision you make. I'm trying to explain to you that you went down this pathway because over a period of time, your sleepiness just went away for whatever reasons. It could be high anxiety is probably the number one culprit. PTSD is a big explanation for sleepiness going away. If you need to be vigilant and hypervigilant because of past trauma, why would you ever be sleepy? Why would you ever want to go to sleep and have nightmares? Why would you ever want to go to sleep and be vulnerable? So these are very logical statements people can hear and they say, okay, well, that's useful information. So what do I do differently? If I don't want to take pills, I say, well, the good news is that biologically, that sleepiness is still inside you. It didn't disappear. There are rare circumstances where people have, say, hypomania or bipolar disorder or other conditions, but those are so rare by comparison to the average severe insomniac who's really just gotten into a long pattern of this type of behavior. And you say, well, we have to start and have some goals that are reasonable. And the biggest goal is, are you willing to spend less time in bed? Because the time you're spending in bed, wide awake, thinking, worrying, is teaching your brain, oh, well, I can just keep doing this. You might as well take your tax returns with you into the bed and work on your taxes and see if that puts you to sleep. So the people hear that, and this is one of the things about CBTI, which is a very well-known weakness among some of the more modern forms of teaching or practitioners that you would never see in the old-time experts who practice CBTI, which is that if somebody comes along and says, I spend 10 hours in bed and I sleep 4 hours, well, by the book, it's okay, well, I want you to drop that down to 5 hours in bed and 4 hours of sleep. And there's some practitioners, I hope it's a minority, but I don't know because of the people who've told me things. I have worries about it. It doesn't keep me up at night, but I do have worries about it. That they'll tell somebody, drop this down to 5 hours. I say, are you kidding me? You understand the emotional relationship between the bed and this person's insomnia, and you're going to try to put, that kind of instruction onto them, and that's when some of these people then just leave. It's like they take the appointment, they go, and they never go back. And I say, well, yeah, that was really an inappropriate instruction for you because it didn't appreciate the fact that this is a big pattern you've got, and it isn't going to change overnight. And without even going into that instruction, I'm sorry, that description that I just gave just now about this, I might not say all that to the individual. I might just say, so you're 10 hours in bed and 4 hours of sleep. Can I get you to wake up maybe 30 minutes earlier? Like we just went from 10 to 9.5 hours in bed. And they're looking at me like, I don't know what that's going to do, but if you want me to try that, you're saying that I'm spending too much time in bed and that if I could cut that down, and you're saying and I've been shocked that there are people who will drop their amount of time in bed by some small number, 15 minutes, 30 minutes, an hour, whatever it happens to be. And they will come back and they will go, that was really interesting. Like, I was surprised. Like, I don't know why, but I kind of slept more, even though we had just taken a little bit of time off my time in bed. In fact, what you told me made sense. And I decided to take another 30 minutes off of my time in bed. And that was even better. And so now what have you done? This is totally about self-empowerment and self-efficacy. And the person is getting that and like, gosh, this is really interesting. And it was funny. One night, I woke up in the middle of the night and I noticed that I was sleepy. And I rolled over and I went back to sleep. So now I know what you're talking about. So these are the kinds of things. You can call it baby steps, you can call it whatever you want, but you can't practice CBTI out of a book. And I don't know what goes on in the field of sleep medicine anymore in terms of the trainings, the fellowships, and so forth. But because I'm seeing in some ways the worst of the worst in my coaching practice, where individuals are coming in and saying, well, I tried that. They told me about sleep restriction and it didn't work for me. And so I, of course, ignore the term because everybody is put off by the term. But we just go through instructions in that particular way. But then again, let's go back now to the really severe cases. What if emotionally they can't do what I just said? Well, that's a big problem. And the question then is that individual not a candidate for any treatment yet because they are now in a category they're in a category that I wrote about extensively in this book, Life-Saving Sleep, and that is their insomnia has been a tool that they have used to not deal with their mental health problems. And those of us in the field who work with really severe insomniacs know these people very well because they will come in and literally say the words, if I could just sleep better, everything else would get better. Now, there is some truth to the fact that if you sleep better, a lot of things can get better. So that's good that they know that. But that's not exactly what's happening with these individuals. They have anxiety, they have depression, they have PTSD, they may have OCD, they may have panic attacks, a whole number of symptoms and conditions, but their brain is so resistant to psychotherapy, dealing with emotional content, resistant to insights, resistance to thinking about self-criticism. Whatever it is, it's like, if I don't sleep, I can become disabled. And in fact, my sleep is disabling me. And you know what? I'm going to apply for disability. And they go, well, why are you applying for disability? Well, because I can't sleep. And they go, no, I'm telling you, I can't sleep. And the doctors, they've given me all these pills. They've tried these psychotherapies. And I've seen cases like this. And it's very sad and very concerning because these individuals don't recognize that there are mental health processes in play that unfortunately they've not been in the hands of a very skilled mental health professional who's going to help them bring this out and realize this is really what's going on. This is what they're quote unquote running from. And so instead they just wrap everything around the problem of insomnia.